Assalamu alaikum. I'm Dr. Abdurrahman Muhammad Alam. Welcome to today's Cataract Surgery Insight into a small people stress, iris hook, and Lucia Iol Implantation. This is a case with a small pupil with posterior synechia and generalized iris atrophy. Form the AC with irrigation and with the help of the spatula, break the posterior synechia in 360-degree manner. Now again form the anterior chamber with continuous irrigation and inject intracameral blue rays under the pupil to stain the anterior capsule fully under the iris. I washed out the blue rays with adrene and filled the anterior chamber with viscot. Then I made the main port with a 2.4 keratome. Now I'm stretching the pupil with the help of two ball chopper. Stretch it adequately to have a decent sized pupil for phacoemulsification. Now perform viscometriasis. The pupil has sufficiently dilated. Now I'm injecting adrene again to cause further dilatation. Then I'm injecting viscot again to cause viscometriasis. Now I am creating the rhexis and retracting the iris with the help of the ball chopper. Since the pupil is becoming small, my rhexis size has become small, so I have introduced the iris hook through the main port. Now I'm continuing with the creation of the rhexis. Now I've decided to implant iris hook for better visualization of the anterior capsule because I want to make the rhexis even larger because it is very small. It is maybe 3.5 millimeter in diameter. So I'm using the iris hook to dilate the pupil, mechanically dilate the pupil. Now with the scissor I have cut and raised the flap. Now I'm guiding the flap with the rhexis holding forceps and creating a larger rhexis. Now perform hydrodissection and hydrodelineation. Now with the spatula perform mechanical cortical cleavage dissection. Refill the anterior chamber with OVD and perform phacoemulsification. Introduce the phaco handpiece through the main port with continuous irrigation. With the Sinski, rotate the nucleus. Perform pre-phaco and sculpt out a central groove in the nucleus in sculpt mode. Now perform vertical chop and try to chop out a wedge of nucleus and emulsify it in the quad mode. This will debulk the posterior capsule and you'll have room for rotation of the nucleus and further chopping of the nucleus will be easy. I'm performing phacoemulsification with the help of the soft cell technique. I've injected viscot followed by HPMC. The viscot has coated the endothelium and the HPMC is forming the AC. Now it is routine nuclear management. You have to chop the nucleus and emulsify it and remove the nucleus. Perform multiple chop of the cataract and remove it in the quadrant mode. Always remember to remove the epinucleus in the epinucleus mode. Before removing the epinucleus, I have injected OVD into the anterior chamber to deepen the AC and push the posterior capsule posteriorly. Now I am emulsifying the epinucleus in the epinucleus mode. There is a piece of small epinucleus shell which is visco-expressed out of the main wound. Now only cortical matter is remaining. Now remove the cortex with the help of the bimanual IA handpiece. Refill the anterior chamber with OVD and increase the wound size slightly to help in easy implantation of the IOL. This is a preloaded IOL. This is a City Lucia lens from Zeiss. Now I'm implanting the IOL into the PC bag. With the help of the spatula, dial the IOL into the PC bag. Now remove all the iris hook in a non-traumatic way. You have to bend it out like this. Don't pull it out, bend it out. Okay. Now perform visco removal in visco mode. With the help of the bimanual IA handpiece, remove the viscot. I was trying to remove this tissue, this fibrous tissue that was attached to the pupillary margin, but it was strongly adherent, so I did not remove it in fear of causing iridodialysis. After removing of the viscot, I am performing stromal hydration of all the wound made for the iris hook and the side port and main port. Notice that the iris is a little bit floppy and there is a bit of iris prolapsing through the right side port. So I did not do visco removal through the side port. Also there is a descemet detachment at the right side port. There is still iris prolapsing through the right side port. I'm trying to reposit it inside the anterior chamber, but there is also a descemet detachment flap at the right side port. So I have introduced a air bubble and I decided to stitch the main wound so that the AC remains tight and sealed, and also will help in tamponating the descemet detachment and attaching it, reattaching it. Now give a stitch at the main port and give knot in the fashion of 3 1 1 3. Yes, 3 1 1 is finished. Now cut the stitch and bury it inside the stroma. At the end of the case, I'll give intracameral antibiotic and subconjunctival dexamethasone. Thank you, my dear friends. Hope this cataract surgery insight video was helpful in developing your surgical skills. Until next time, thank you.